recovery. Increasing attention has been paid to reduce both the number of sizes of laparoscopic incisions, hence the emergence of laparoendoscopic single-site surgery, with the ultimate goal being the absence of any visible scar. So Vnotes represents a significant advancement in minimal invasive surgical techniques, combining both laparoscopic and vaginal surgery. It provides patients with several benefits, including improved cosmesis, reduced pain, quicker recovery times, and lower risk of complications associated with abdominal ports, such as visceral injury during port insertion. And additionally, it minimizes the likelihood of surgical site infections, hernias, and scarring. The approach also facilitates early control of blood supply to pelvic organs, leading to reduced intraoperative blood loss. And in comparison to conventional vaginal surgery, this method allows for direct visualization of abdominal structures, enabling safer dissection and access beyond the pelvis. This capability expands the range of procedures that can be performed. However, implementing Vnotes presents several challenges. The surgeons often encounter a steep learning curve, requiring a balance between mastering the technique and ensuring patient safety. The number of working instruments inserted is limited, and the loss of triangulation of straight instruments may also result in restricted movements and clashing of the instruments. So what motivates us to adopt Vnotes, and where do we currently stand? Several of our colleagues attended the Hong Kong GS Vnotes workshop in June this year, where they gained some hands-on practices with simulation models. And since July this year, we have attempted 4 Vnotes total hysterectomy plus BSO cases. And of these, 3 were successful, while 1 case required conversion to TLH BSO due to failed insertion of the wound retractor. So our motivation to start Vnotes is driven by an increasing body of research that demonstrates its non-inferiority and safety compared to conventional laparoscopic surgery. The first study on Vnotes for surgical staging in endometrial cancer was published in 2014. And since then, additional studies have emerged comparing Vnotes to conventional laparoscopy in gynecological malignancies, highlighting the feasibility of the technique and its comparable surgical outcomes. Our team's vision for Vnotes is hopefully to eventually apply these techniques to oncology cases as well. And moreover, Vnotes has shown potential benefits for obese patients, which reduces the difficulty of managing bowel displacement and allows for less steep Trendelenburg position. The lower pressure pneumoperitoneum compared to conventional methods results in reduced anesthetic ventilation requirements, and additionally, it lowers the risk of insufflation-induced bradycardia and also CO2 absorption, and contributing to decreased postoperative pain. This is an article published in EJOG in 2021, reporting an international consensus-based statement to help guide a basis for adopting Vnotes into clinical practice. So some factors to consider during patient selection includes factors that cause limited access and loss of triangulation, such as in virgin or nulliparous women. Factors that can distort the pelvic anatomy or cause adhesions with increased risk of visceral injury. Smaller size uterus may be easier to start with, but larger uterus can also be feasible for more experienced surgeons, and if the disease is benign, to allow safe morcellation if required. As Vnotes hysterectomy is performed through combined anterior and posterior colpotomy, while other Vnotes procedures are performed through a smaller incision, either posterior or anterior colpotomy. Therefore, Vnotes procedure for indications such as annexal surgery alone or myomectomy are technically more challenging due to the reduced triangulation when compared to hysterectomy. And hence, it is advised that the surgeons can gain more experience in venous hysterectomy first before starting to perform for other indications. So our case selection is based on previous factors as well. All three patients with successful Vnotes were multiparous patients with normal body build. They have no previous surgeries done before, and they have been followed up in our unit for pelvic organ prolapse from stage 2 to stage 3. All of the cases had pre-op ultrasound done, showing a small uterus with or without small benign-looking cyst, and pre-op CMG was done for all cases. So the pre-op preparation was actually similar to vaginal hysterectomy with normal saline vaginal douching performed before, and prophylactic antibiotics were given on induction. And preoperatively, the patient's understanding on the procedure and its aim and benefits were checked, and realistic expectations were set, and a plan in case of failed vaginal access was also discussed. So for the operation, we also followed some standardized steps. Let me just quickly go through these steps. So firstly, the patient is placed at 0 degrees. The operating table is placed at 0 degrees, and a circumferential incision on the vagina around the cervix was made. Bladder and rectum is mobilized away, posterior colpotomy done, followed by anterior colpotomy, and transection of the uterosacral ligaments were performed. Then the gel point VPAP system was set up. Chokers were placed 1.5 centimeters away from the plastic ring, and the wound retractor inner ring was inserted around the cervix in the peritoneal cavity. Then we need to check whether there are any tissues trapped within the inner ring. Then the gel seal cap is secured, and patient will be positioned in 20 degrees Trendelenburg position. We set the pneumoperitoneum with a maximum of abdominal pressure to 10 millimeters mercury. So let me show a short video regarding the surgery. So I'm sorry we don't have the video showing the insertion of the retractor. This is the part where after insertion, after we introduce the laparoscope, and we can see we're currently sealing the uterine vessels, and the surgeon follows as close as possible along the uterus to avoid injury to the surrounding structures. So this is actually showing the left side of the patient. So we perform as close as possible to the uterus, and we can see the structures here, the cervix, the broad ligaments, the left ovary, and we place a gauze inside to absorb the blood and also displace the bowel. So during the operation, the surgeon will also need to frequently check the level of the fundus of the uterus as well. And we're working towards the IP ligament. So here we can see the ovary and the course of the left ureter, which is quite far away. And we can actually clearly see the peristalsis of the ureter. And this we can ensure that it is very far from the surgical field, and we can confidently seal the IP ligament without worrying injury to the ureter. So there are some ups regarding the Vnotes operation include superior visualization of the surgical field, allowing for more precise dissection and better anatomical orientation. In fact, the wound retractor enhances exposure to the pelvic cavity and can help displace the ureters laterally, reducing the risk of direct injury during dissection. Its design facilitates gentle tissue retraction, minimizing excessive pulling or stretching that could lead to tension-related injuries to the ureters. Some tips or tricks for the operation include ensure hemostasis by cauterizing thoroughly before cutting. And since Vnotes involves significant retraction and rotation of the uterus, this precaution can help reduce the risk of tearing the blood vessels. And part of the pedicle on one side could be left first, and then we repeat on the other side to keep the uterus attached to the side walls for more easy manipulation to avoid the uterus from floating. And always go close along the uterus to reduce visceral injury. And as the camera is inserted parallel to the endoscopic instrument, the depth perception is reduced when compared to conventional laparoscopy. Therefore, the surgeon must at all times be aware of any potential tissue contact past the tip of her instruments, particularly the bow. So here comes our last case of attempt of Vnotes. So she is a 68-year-old lady, para 3 or previous NSD. She's an obese lady with BMI of 38, and she presented with postmenopausal bleeding. Ultrasound showed normal sized uterus with thickened midline and no adnexal OHC was performed, and it showed grossly thickened endometrium and suspicious looking with prominent vessels. And Pipel was done and came back to be grade 1 endometrioid carcinoma. Her CA125 is slightly elevated. And pre-op examination was done. The vagina was actually quite roomy. She had a normal cervix and uterus was not palpable and parametrium was free. Pre-op MRI was done, showing a 4 centimeters tumor distending the cavity with less than 50% myometrial involvement. There were no lymph nodes or distant metastasis. So preoperatively, this patient was counseled regarding chance of failed vaginal route alone and may need additional laparoscopic assistance and chance of failed MIS requiring laparotomy. The initial steps of the Vnotes were the same, and both anterior and posterior colpotomy was achieved. But during insertion of the wound retractor, the vaginal cavity failed to distend adequately, although pneumoperitoneum was actually achieved. And afterwards, we noticed continuous oozing from above, and the surgical field was quite inadequate to identify the source. And eventually, we need to convert to laparoscopic route. And afterwards, we found actually the source of bleeding was from the right torn uterine vein, which is likely due to the insertion of the wound retractor. So in the end, this patient had TL-HBSO performed. Blood loss was 1.2 liters with 1 unit of PAC cell transfused. She had a short stay in ICU, and post-op recovery was uneventful, and she was discharged on post-op day 4. So what were the difficulties we encountered during our first attempts of Vnotes? Firstly, difficult insertion of the wound retractor, especially in cases with long and deep vagina and no prolapse. And there was inadequate exposure due to insufficient retraction or poor lighting, causing the poor visualization. And the forceful insertion of the retractor also caused injury to the vessel, and we were unable to identify the bleeder near the edge of the wound retractor, leading to the blood loss. Secondly, the surgeons also faced steep learning curve and were quite unfamiliar with the view, which was upside down. And there were also loss of triangulation and clashing of the instruments during the operation. So regarding the outcome and the complications of our 3 successful cases, in fact, there were also some hiccups as well, causing a longer post-operative stay. So for the first case, patient post-operatively was recovery well and discharged on post-op day 3. During follow-up, she is asymptomatic and there were no urinary symptoms. For the second case, she presented with right lower quadrant pain on post-op day 2. Ultrasound showed right mild hydronephrosis of 1.8 centimeters, while the left side was normal. The renal function was normal, and CT urogram was performed on post-op day 3, showing mild hydronephrosis of the right kidney, but the location was at the right upper ureter, and there were no definite obstructing lesion down below identified. She was given a course of empirical antibiotics and managed conservatively. And at follow-up, she had no urinary frequency or urgency and otherwise no other complaints. Follow-up ultrasound showing the right renal pelvis was 1.4 centimeters. The renal function was still normal, and she will be reviewed by urology later. So for the third case, we also found to have post-op deranged renal function with from the baseline of 150 to 400. Also, we found right hydronephrosis up to 3 centimeters. The blood culture came back to be E. coli and MSU showed Pseudomonas. CT urogram was performed. There were no evidence of urinary tract injury, but found right renal stone and mild hydronephrosis. So the impression was actually pyelonephritis. She was given a course of antibiotics. The renal function was improving before discharge, and ultrasound before discharge showing improvement of the right hydronephrosis and resolution of the left side. During follow-up at the urology clinic, her creatinine was downtrend back to 180, and ultrasound showed resolution of the hydronephrosis already. So this table compares Vnotes to vaginal hysterectomy and total laparoscopic hysterectomy alone, performed over the past 6 months. It serves as a brief comparison, noting that the surgeries were conducted by different surgeons with varying levels of experience. The operation time for Vnotes is longer than that for vaginal hysterectomy, and this extended duration can be attributed to the surgeon's limited familiarity with the gel point insertion during their initial attempts. And additionally, the upside-down view in the Vnotes posed some challenges for the surgeons as well. The operation time also included some extra procedures such as colpocolysis in the Vnotes cases. While the mean time for Vnotes is longer, it is not drastically different from the TLH group, but this can also be due to a wide variation of operative time within TLH group due to different levels of experience of the surgeons. So further comparison among the procedures performed by the same surgeon would be beneficial. And in the Vnotes group, there were increased blood loss in the first few cases, which may be linked to the longer operation time. The length of stay for patients undergoing Vnotes were higher, but likely influenced by those 2 cases that require extended hospitalization due to the hydronephrosis. So more Vnotes procedures should be conducted to enable more accurate comparison. And for all the 3 procedures, the types of analgesics administered were similar, and most patients achieving effective pain control using only simple analgesics such as Panadol. So what are our surgeons' feedback on their first few attempts on Vnotes? It is actually a good start and feasible option of MIS. It gives a positive learning curve for surgeons to improve their skills. As more studies and training programs develop, surgeons may find that mastering Vnotes technique is a valuable addition to their skill set. It also allows for more comfortable positioning of the surgeon and reducing fatigue during the longer operative procedures. It also allows broader surgical applications as it can be adapted for a variety of gynecological surgeries. And it also allows clear identification of anatomical structures for safer dissection. Although the operative time is longer due to low experience and unfamiliarity with the insertion and Vnotes view, the surgeons are confident that they will improve with more practices. And the clashing of the instruments during the procedure are quite inevitable with straight instruments. And we could also consider using angled instruments or 30-degree laparoscope for a wider range of view in the future. So how can we improve in our future practices? Firstly, better case selection, starting with easier cases to build confidence and skill. Secondly, conducting a detailed preoperative assessment is crucial for selecting suitable cases for the first few attempts at Vnotes. And properly manage patients' expectation through good preoperative counseling, explaining to them the potential difficulties and chance of failed Vnotes, and learning from challenges. For example, in the case of failed Vnotes due to difficulties with the insertion of wound retractor, we can consider using stage sutures over the anterior and posterior peritoneum to facilitate the ring placement. Also a gradual transition from conventional vaginal surgery to Vnotes by starting with various levels of hysterectomy, and always develop a backup plan and discuss it with the patient before the procedure. And most importantly, more practices. So this is the first paper to publish surgical experience with Vnotes hysterectomy in Italy, and it's the first article analyzing the learning curve of Vnotes hysterectomy from the first cases to the more complex cases in a routine surgical activity of an experienced operation team. So the primary outcome was surgical time. Secondary outcome were intraoperative and postoperative complications, length of hospitalization, and postoperative pain. The learning curve showed 3 phases. For phase 1 of competence, accumulation of initial experience from case 1 to case 5 with a stable operating time. Phase 2 of proficiency with a gradual reduction of mean operating time, and then further consolidation. Phase 3 of mastering with the introduction of more complex cases after 30 cases were performed. So we are currently still at phase 1 with accumulation of initial experience, and hopefully we will be able to perform more to attain a level of proficiency in the near future. So in summary, Vnotes is feasible and reproducible technique characterized by relatively short learning curve and a potential reduction in perioperative complications. With increased practice, surgeons can develop their skills and confidently manage more complex cases, allowing for broader adoption of this innovative approach in surgical practice. So special thanks to Dr. K.M. Chow and Dr. Mimi Fong, Urogyne team, Dr. K.W. Lee and S.E. Wong, and Gyne Oncology team, Dr. Kong and Dr. K.Y. Zhang. Thank you.
Okay. Thanks, Priscilla, for the presentation. I'm sure that there will be a lot of discussion and comments from our expert panels. So Dr. Tang and Dr. Lee, do you have any comments on this?
Oh, hello. Sorry, yeah. I forgot unmute. I'm saying that I'm just in stage 2. I'm not a expert. Recently, I present my series in the OGSHK ASM. At that time, I'm saying that I have low conversion, but just after that presentation, I have 1 case of conversion because similarly, there is leaking after I put in the wound protector. And I think the problem is quite similar because the patient have a rather long vagina, so that we cannot put the inner ring securely. So when we push the anterior part of the ring, the posterior part will slip out. When we push the posterior, the anterior will slip out. So I think there is another size of gel pond V path that is a bigger one, but not quite readily available in Hong Kong. The inner ring is a bit longer. I think in case of a very long vagina, we can try to use the bigger size one. Okay. As you said, you may try to put stage suture, but I think if the problem is long vagina, it is very difficult to put a stage suture for your insertion. Okay. So for you have 4 cases, but have 2 cases have some hydronephrosis. So the cause you said is urinary infection. So do you find there's any contributing factor for this relapse surgery to have such a high proportion of post-op hydronephrosis?
I think for the third case, actually this patient had some renal stones as well. We're not sure whether it is really related. But from the CT imaging, it showed the obstruction was above the level of those stones, and then there were no dilation of the ureter below that level. So maybe, I'm not sure, maybe the third case is not really related. For the second case, this patient did not have any previous ultrasound done before, and she had no urinary symptoms before. So we didn't do any workup before but this is really a new symptom after the operation. But during the operation, actually the right side of the ureter was visualized. But honestly, the peristalsis is not as clear as the left side. But the operation was done as close as possible to the uterus. So at that time, our surgeons did not think there were any difficulties during the operation that might cause any injury. So we're actually not sure. And I also looked at research on whether this approach will actually make some of the patient have transient hydronephrosis after operation. It seems like there are not a lot of reports. There are some reports saying even with an open hysterectomy, that could be transient hydronephrosis. So we're not really sure what is the cause of the hydronephrosis in the second case. Yeah.
Thank you. And also one more comment is that you stress quite a few times that you need to dissect as close as possible to the uterus. Okay, but did you attend the relook workshop recently in Hong Kong?
I did not go to,
Oh,
I did
okay.
not go to the workshop. Yeah.
And the speaker, Dr. Hardam, give us the tips that we should not go too close to the uterus because the ascending branch of uterine artery will have many branches to the uterus. If you go too close to the medial of the ascending artery, in every cut you will open up some small branches, making the hemostasis more difficult and more bleeding. So he advises to go a bit lateral to that. But of course, you need to aware where is the ureter. Okay, so I think I tried this approach. Is actually cause less bleeding and the pain will be much more clear. So going too close to the uterus will be a problem.
May I add a little bit on it? I perform a lot of vaginal surgery, but to be honest, I don't do Vnotes. So I just look at it from the point of view of vaginal surgery. Now, firstly, vaginal surgery if you do vaginal hysterectomy, it is very difficult for you to injure the ureter, because what you do is you draw the cervix downwards, and the ureter doesn't come down with the uterus. And with the retractor, the ureter is well displaced laterally, and you can actually see it. If you are using your diaphragm, although there's a potential thermal spread, but because the distance between the place where you apply your diathermy and the ureter is so far away, I don't think there's any chance of you injuring the ureter as a result of the diathermy. And as far as KK's comment on the location where you apply the diathermy, my feeling is slightly different. Because if you look at the anatomy of the uterine artery, basically it has got 3 segments. You have the descending, the arch, and the ascending. If you're doing your vaginal surgery, like a hysterectomy, probably you would be tackling the arch of the uterine artery, for which it can stop all the bleeding from the rest, the distal part of the uterine artery. Of course, you can have venous bleeding, but certainly not from the branches arising from the uterine artery, which means that if you are able to coagulate or diaphragmize the arch of the uterine artery, the rest of the distal part of the artery, like the ascending segment and the small branches, is highly unlikely giving you much bleeding. Of course, the venous one may give you a little bit of bleeding, but I don't think it should affect the outcome of the surgery very well. So overall, I think it's very safe from the point of view of injury to the ureter. It's very safe. There's hardly any chance of you injuring that, unless the surgery was very difficult. But from the 3 cases you mentioned, I don't think they are basically small injuries, and I don't see any chance of the ureter being injured as a result. And for the bleeding, if you pull onto the cornea, of course, there could be bleeding. And if you cannot see the site very well, that means the exposure is affected. The best bet is you convert it. All right, don't try to stop the bleeding by blindly diaphragmize the area. That could be extremely dangerous. So after all, you need quite a number of cases to attend your so-called efficacy in doing this. So although I'm not a venous surgeon, but I do a lot of vaginal surgery, so I know exactly what problems one would have to face. All right, so I agree with you. Start with easy ones. Yeah, thank you.
So I can see there are some questions from the participant. So there's a question on whether is there any benefit over traditional vaginal hysterectomy in Vnotes. I think he means is there any advantage of Vnotes over vaginal hysterectomy alone?
I think as mentioned just now, actually for Vnotes, it allows us to be able to improve of access to higher pedicles and also surgical fields. So sometimes during vaginal hysterectomy, for example, if the ovaries are attached very high up, we may not be able to reach that level with during vaginal hysterectomy. So it allows more procedures to be performed in case conventional vaginal surgery alone is not able to achieve. So it also allows for direct visualization of the structure. So it allows for easier dissection as well.
So
I think for this question, I also encountered this question after my presentation. So my view is that if you are very good vaginal surgeon, you do a lot of vaginal hysterectomy with undescended uterus, there's no need for you to learn Vnotes, okay? But in our generation, the training of vaginal surgery is not that proficient. So many of us are not that familiar with the vaginal surgery. So Vnotes can help us to do a vaginal lateral orifice surgery with the help of laparoscopic instrument. And another advantage is that although it is not as good as laparoscopy in stopping bleeding, because the visualization is not as good as laparoscopy, but certainly it is a bit better than vaginal surgery. So if we have some higher pedicle bleeding, Vnotes can help us to secure this kind of bleeding more easily than vaginal surgery. And also for the oophorectomy or BS sublingual oophorectomy, it is more easier to learn with a Vnotes setting rather than just a vaginal surgery setting.
Actually, venous surgery is not easy at all. It's another form of single port surgery. And I think Dr. Lee Priscilla has also mentioned about the clashing of instrument, the lack of triangulation, and sometimes it's difficult to control bleeding because suturing by itself is very difficult down there. So my feeling is because I used to do vaginal surgery like hysterectomy. My experience is I encounter not uncommonly cases of vaginal void prolapse afterwards for the single reason that it was due to this extrafascial or hysterectomy. That means you have to cut the uterosacral ligament right from the beginning. And for that matter, the pericervical ring was disrupted, and there is a chance of prolapse after 10, 20 years. That was my experience because I started doing that years ago. And so personally, I think Vnotes is good for easy cases. And for those very experienced, yes, they can tackle everything. Like Gong Xiuming from US, he can do everything. But on a whole, I think it's not an easy approach as compared to conventional one, because controlling bleeding with conventional one is a lot easier. You see where the blood comes from, and then you can stop it. Or at times you can do suturing, but suturing down from below is extremely difficult because of the limited space available, and the exposure is only one way, not different. Years ago, a doctor from Japan, Endo-san, he actually used a camera to put in, and then use a computer to convert the image into something like a opposite, like a mirror image, before you could see things. I think all this can be done, but it's not easy to achieve that. So I think Vnotes has got its place, like ovarian cyst, small, maybe posterior fibroid, simple hysterectomy. It has got a lot of advantage, as Dr. Tang just mentioned. But if one has to attain proficiency for typical cases, it wouldn't be as easy. So that's my viewpoint on the subject. But I do encourage people to go for some new modalities of treatment. It offers patient additional advantage, provided you have a very good case selection. Yeah, that's how I feel.
Okay. Let's move on to the next presentation. Thank you, Priscilla, for your excellent talk. So, would you introduce your next speaker?
Yes, the next speaker is Dr. Eunice Wong. She is graduated from the University of Hong Kong, and then she entered ONG training in the United Christian Hospital. She is currently a high trainee in my hospital, and today she is going to talk about the use of ICG in benign gynecological surgeries. So Eunice, please start your presentation.
Sorry, I'm encountering some problem. I will be back very soon with regarding the presentation sharing. Can you see my screen presenting now? Should be all right. Okay, so I'm Dr. Eunice Wong from United Christian Hospital. I'll be sharing ICG use and benign gynae surgeries. So ICG stands for indocyanine green. It's a water-soluble tricarbocyanine dye. So this is the package, how it comes in the package. You have a vial and also 10 ml of sterile water. It exhibits broad fluorescence in the near infrared range when exposed to 806 nanometers of light. So in the presence of the infrared light, ICG induces the electrons transition from a lower energy level to a higher one. So in this process, energy is emitted in the form of photons and heat. So it contributes to fluorescence generation. It's 95% bound to plasma protein. It doesn't undergo metabolism and is only cleared exclusively by the liver. And via the bile in the free form, the elimination half-life is around 2 to 3 minutes. The rate of the vascular clearance from the vascular components is around 20% per minute. And after 20 minutes, no more than 4% remains in the plasma. So it actually looks like Firefly. So that's why there's a fetal system named Firefly after this property. So more about ICG. So regarding the adverse drug reaction, actually it's very mild. Majority of them are mild, contribute around only 0.15%. Majority of them being GI disorders like nausea, vomiting, fecal discoloration, headache, and also pruritus, urticaria, and diaphoresis. However, there are also chance of significant allergic reactions. So around 0.05% of patients experience bronchospasm, laryngospasm, and anaphylaxis. The mechanism is majority unknown, but it was noted that patients who have liver disease and also kidney disease should have a cautious use because around 9% of these incidents were reported in dialysis patients. Patients with hypersensitivity to iodides are absolutely contraindicated for ICG use. And there are a precaution on pregnancy use with FTA category C and also in lactating ladies. The cost of ICG is actually very cheap. In our unit's pharmacy, one vial of 25 milligram of ICG only costs around $350 per vial. It has excellent safety profile. It was actually approved back in 1959 by the FDA. It was first used in assessing cardiac output, hepatic function, and also ophthalmic angiography. Due to the new infrared emission imaging property of ICG, its use has been expanded surgically. For example, in oncology cases, it's used to map the sentinel lymph node, and also in hepatobiliary surgery to look at the liver, in intestinal tumors to decide on the resection margins, on the perfusion of the bowels after anastomosis, and also in reconstructive surgeries. So what about gynecology? So other than in sentinel lymph node mapping is actually expanding to benign gynae surgeries as well. For example, in assessing vascularity, in looking at perfusion, which may also imply tissue viability. For example, in cases of torsion of the ovary, adnexal cyst, and also fallopian tubes. Assessing vascularity of bowel and also ureter, for example, after ureterolysis, and rectal shaving after endometriotic surgery. And also used in delineating anatomy, for example, demarcation of the bladder, ureter, bowel, and also in uterine cavity, which is useful in doing myomectomy, or when you're doing a niche operation, you want to avoid, you want to decide on the depth of your surgery. And also in cases with pelvic endometriosis, so you ICG can actually help to identify endometriotic deposits and also implants, and actually useful in looking at non-pigmented lesions as well, which may be seen as fibrosis. So this is a table showing how our unit give ICG. So depending on the purpose on why you want to use the ICG, we use different dosage, or the route of injection is also different. So for perfusion assessment, ICG is given intravenously. The usual dosage is 7.5 milligram followed by for 10 ml normal saline push. And for endometriosis mapping, we also give it intravenously, but the dosage is dependent on the patient's body weight. For example, we give 12.5 milligram, which is equivalent to 5 ml after dilution in a 50 kilogram patient followed by saline push. The dilution when we use ICG intravenously and also during intraureteric wise, we give 25 milligram of ICG and we dilute it into 10 ml of sterile water. So this gives 2.5 milligram per ml. And after intravenous push, you can actually visualize within seconds where the ICG has reached within the blood vessels, can last up to 2 hours, and the boluses can be repeated with a maximum dosage up to 2 milligram per kilogram. And regarding ureteric mapping, we give the ICG intraureterically. And last up to 8 hours according to literature mapping in oncology cases. We usually inject ICG in the cervix. So superficial injection 1 to 3 millimeter, and for deep we give 1 to 2 centimeters. The usual dosage is around 2.4 ml, and the dilution is different. It's actually more diluted. We dilute 25 milligram of ICG in 25 ml of sterile water, giving 1 mg per ml. And after injection into the cervix, it's seen within minutes and lasts for up to an hour. Please note that the dilute ICG is only given in water and not normal saline, because if we put ICG into normal saline, it will precipitate, so it cannot be used. And after ICG has been diluted, it can be used up to within 6 hours. So how do you actually visualize ICG during your operation? So we have special video systems and camera that can be used. For example, Striker. This is actually the setup in usage OR as well. So you've got the OR, the hub, the monitor, you've got a pneumo inflator, you've got a camera unit, light source, and also the SPI-Fi, and also the printers. I will explain more later in the next slide. So this one is a 4K surgical display monitor, and you have the hub, which kind of offer total control of the entire system, and the warm, heated insufflator, and also humidified, and also allows smoke evacuation. And the SPI-Fi and the VPI system is the heart of the system, because it allows the fluorescence imaging to be performed. And you also have the light source and also the transmitter and receiver. And on the top here, we can see this is normal white light visualization of the bowel. This is overlay mode, so you can see fluorescent on top of the normal white light image. You can have the SPY fluorescence mode, so it's black and white. And you can also opt for the color segment fluorescence mode. Other than Striker, actually our unit uses the cow stores more often. We use the 4K 3D and Rubina system. So this system combines 4K 3D and fluorescence imaging technology into one. So similar to the Striker one, you can also have white light image overlay on top, as well as just the monochrome as well. So I'll go on to the next slide, which also shows more about the Rubina system. So this is the image 1S. So it helps you better visualize. It actually combines all the other components together into one. So yes, and then next is the TipCam 1 Rubina camera, also 4K, and it's available in 0 degrees and also in 30 degrees. It's an outer diameter of 10.3 millimeters and weighs about 420 grams. And The other one is the power LED Ribena. So it's a cold light source based on the LED technology, can emit white light as well as fluorescence application. So displaying near infrared or ICG. And of course, we cannot miss our robotic. So Da Vinci also has the Firefly system here. So this is the one you use when you want to use Firefly ICG in Da Vinci system. It's compatible with the 10 or 10i surgical system. Also available in 0 and also 30 degrees. So after the brief introduction on how we for example, the dosage, how it's given, and what video system is required, we move on to the part where I'll share some published papers or research regarding ICG use in benign surgeries, and also some videos and regarding our UNES experience of using ICG. So we have used it in assessing perfusion. For example, in cases of annexal torsion, we have also used ICG in dilating anatomy of the ureters, and we have also used it in endometriotic surgeries as well. And actually, you can also use it in assessing perfusion, for example, after rectal shaving. But our unit hasn't been doing any rectal shaving yet, so this will not be included in my subsequent presentation. So first, assessing perfusion and tissue viability in torsion. So this is actually there's a paper published back in JMIG, and it was actually back in 2022. So they want to look at ICG use in torsion cases to look whether the tissue is viable after detorsion. So traditionally, we assess the viability by only gross inspection, for example, tissue color, whether it's purplish blue looking, and whether the color has changed to suggest there might be perfusion. So traditionally, if the ovary or the tubes looks very dark, purplish, SO or ovarectomy was performed. However, in recent years, the suggested approach is to preserve the ovary by untwisting the pellicle and then perforating cystectomy even when it's necrotic looking. So this study uses ICG and hopes to determine whether it's feasible to use it to determine whether there's actually perfusion after detorsion that may better support your decision to perform a conservative surgery. So patients who are pregnant or have suspected malignancy or have significant cardiovascular or pulmonary disease, sepsis, renal failure, or liver failure excluded. And of course, patients who are contraindicated to ICG use are also excluded. So in the paper, in the research, it was conducted in the USA. They used the Firefly near-infrared technology. So if the anexa appears to be tossed, it was first untwisted, and then a loading dose of X ml of ICG that was then injected intravenously upon by the anesthetist by the surgeon. So unfortunately, the dilution of the ICG that has not been mentioned, so I cannot confirm whether it's the same as our unit. And after injecting the ICG, and then the surgeons will then observe for up to 10 minutes and see if there's any change in the color of the ovary or the tossed anexa. So they define that perfusion is present if they can visualize the ICG dye in the involved ovary or the tube, causing the structures to turn green. If no perfusion was visualized after 10 minutes, after the first initial bolus injection, they would give another 4 mL of ICG and observe for another 10 minutes. This process can be repeated in additionally total 3 times, so a maximum 20 mL of ICG is given. They want to minimize the time under anesthesia, so the surgery could not be extended for more than 1 hour solely for this research purpose. And in the event of intraoperative adverse event, patient safety will definitely be prioritized over adherence of this protocol. And ultimately, the decision whether you want to preserve or conserve the ovary was determined by the operating surgeon. So this shows the results. So out of the 12 cases, actually 2 patients ICG perfusion, so they had ICG resection performed. And out of the 10 cases they were recruited, out of the 12, 10 out of 12 total recruited, 10 have ICG perfusion present, so had ovarian conservative surgery performed. And all the cases were admitted via the A&E department because they presented with severe abdominal pain. And in the 2 cases, the decision to perform oophorectomy was actually decided by the operative surgeon. And one histology came back to be necrosis, and the other one came back to be hemorrhage and congestion. And the operative time ranges around from 48 down to 9 up to 94. And in general, I think this is a minute, so 70 up to 734 minutes is actually a very long time. And in the patients who had ovarian conservation surgery, 10 of them, only 8 of them had majority of them have only one first initial bolus injection of XCC of ICG. And in patients without perfusion or oophorectomy, which are the 2 remaining cases, they had up to 14 mils of ICG injected. And the mean time from the injection to the visualization of ICG was around 1 minute in the 10 cases that had perfusion. And the size of the anexomas was 8 in average. Yes, so regarding the discussion of this research paper, so actually demonstrated that 1 minute is actually very fast. 83% of cases you can see the ICG die already after the injection. And with 2 cases requiring more time owing to absent perfusion upon initial dye administration. And all cases demonstrating the ICG perfusion were managed with entire or partial ovarian conservation. And actually, one of the 10 cases that had conservation had absent Doppler flow, but then it was intraop was demonstrated as perfusion with ICG. And it also demonstrate excellent safety profile because there were no cases with adverse outcome and no patients withdrew from the study. So regarding our unit, we also had ICG used in anexal torsion cases. So the first case is a 17 years old secondary 5 student who is a virgin, has no past history of gynae surgery or other abdominal surgery. She was admitted via the A&E for right lower quadrant pain and also vomiting. Examination showed right lower quadrant tenderness with no other peritoneal sign. Ultrasound pelvis showed right annexal unilocular anechoic cyst measuring around 7 centimeters with no suspicions of malignancy. And there was whirlpool sign on ultrasound with a suspected torsion. So patient and parents were counseled for diagnostic laparoscopy and proceed, and they agreed. So we proceed to diagnostic laparoscopy. And this is the laparoscopic view of the video. Left tube and left ovary, and this is the right side. And we can see some blood-stained peritoneal fluid in the pelvis. The left tube and ovary, they are normal. You can see the right ovary is enlarged with a cyst. And there's a torsion at the ovarian ligament. This is also the tube. It's also torsed as well. Okay, so now this is being detorsed. Okay, so move on to the next clip. So due to a technical problem, we do not have the video footage on ICG before the detorsion, but we do have a footage of ICG perfusion after detorsion. So ICG was given intravenously to the patient. And you can see there's ICG perfusion in the right ovarian tissue after the detorsion. Hence, conservative ovarian surgery has been performed in our patient. And this is another case. I'm sorry, we do not have a video, but we have photos. So in this case, would you do SO for the lady, or would you do ovarian conservation surgery? So with the help of ICG, we're more confident that you can actually perform an conservation surgery to the patients. This is before the detorsion. And this is after detorsion. You can see the green color coming in. Okay, so other than assessing perfusion, for example, in cases of detorsion, we also you can also use it to delineate anatomy. Of course, to us, we usually worry about ureteric injury. So this is a paper published in the Medicina, I think. Yeah. So it was actually a Korean study, and they used ICG in laparoscope or robotic assisted gynae surgery. So they also use ICG in cases of complex lap or robotic assisted surgery. And they want to identify the ureter from the pelvic ring downwards towards in all cases. So actually the authors gave us some tip on how to inject the ICG as well. So other than intravenous injection, you can also use a cystoscopy that to insert the ICG inside the intraureteric orifice. So in here, they don't use a cystoscope. The authors use a hysteroscope into the bladder, and then they dilute 20 milligram of ICG with 10 cc of sterile water. And our unit also uses this dilution. And then they inject 5 ml into each of the ureters. And it was marked that please do not exert excessive pressure, so that the ICG won't extravasate. And then they keep the catheter tip in the ureteral orifice for 1 to 2 minutes to maximize the stay of the ICG retention within the ureter. And then afterwards, they remove the catheter. And they also mentioned that it's useful to have a guided ureteric catheterization to approach the orifice. So this is the photo published on the paper. So this is the catheterization of the ureter, and also how you see the ureter on laparoscopy screen here. And that was the overlay mode. And this one is the monochromic mode. So everything is black and white, other than the ICG, which is green. So 26 out of the 26 cases, they had the catheterization showed ICG. And the blood loss was around 180 mils in the cases, and the operation time wasn't as long as in the previous paper use cases used in the torsion. And the mean post-operative stay was only around 4 days, and no case had post-operative complication. So our unit actually used cystoscope to actually catheterize bilateral ureters. So this shows the setup of our tray. So we have got the KY jelly with lignocaine. We've got the different size of the cystoscope sheath. We've got the obturators as well. And we usually use the 17 French cystoscope sheath on the left side. And we also use the UCath. Okay. So the space between each small marking is 1 centimeter. And with 1 thick pen, it's 5 centimeters. 2 bands is 10. 3 is 15, etc. Okay, so it will help you to gauge how much depth you put into the ureter during the catheterization. So we've got some footage to share regarding our units on how to do the ICG. So this footage shows that we've performed the cystoscopy here, and then we are catheterizing. This is the patient's right ureter. There's a guide wire tip just now, and then we're advancing the UCAS centimeter by centimeter. This is 5 centimeters. And okay. And once you are put into the 10 centimeters, the nurse will help to put the lock on the UCAS. And then afterwards, we'll instruct our nurse to help inject ICG. So you remain steady, you hold the scope, the UCAS is inside you, and then give the ICG. The nurse will pass the ICG to the surgeon, and then we'll administer a slow push. Oh, you can see the ICG here. Okay, and the procedure is repeated on the contralateral side. And after injection, we keep the UCAS for at least 1 to 2 minutes. Okay, and this is the right side. You can see entering the right side. You can see the orifice here. Okay, the guide wire and the UCAS. I'll fast forward this a little bit. We move on to the next slide. So on the right ureter, your catheter is inserted up to 10 centimeters. Just now, you can already see, I think this one is duplicated footage. And you can see this is the laparoscope. So after 10 centimeters, you can see it up to here. But above that, you are not able to visualize the course of the ureter. Okay. And this is the left side, in which actually the left ureter was advanced and catheterized up to 20 centimeters. You can see the course above, which is more definite as well. Not just 10 centimeters. Okay. So this is a surgical clip. You can see that the right ovary is actually adhered to the right pelvic sidewall with fim's adhesion to the large bowel. But after ICG injection, you're actually more confident where the ureter is. And you can safely perform the adhesiolysis between the right ovary and also the adhesion bands. So we actually have another case with difficulty in identifying the left ureter during Vnotes. I was incarcerated left ovary due to the torsion, and surgical field and even the gauze were heavily contaminated by the ICG after emptying the bladder by the cystoscope. So yes, we learned heavily from that surgery that we should not over-distend the bladder, and we should drain the bladder with Foley and also rinse the perineum with normal saline before proceeding to Vnotes after the cystoscopy. Okay. because we're running a little bit short of time, so I will move on quite quickly. And if I have time, I have the video on another hard disk that I will go back to it again for you. So other than delineating the anatomy, other than looking at ureters, I've mentioned before, you can actually some ladies had surgery done for rectal shaving. You can also use ICG enema to look at that. And you can also inject it into the uterus to look at the tubal patency, to look at the uterine cavity in mammectomy cases. You can also inject it into the bladder for bladder delineation, and also into the rectum for rectum delineation. And the dilution are slightly different for each purpose. Yes, according to the literature. And for intrauterine use, we put in a uterine manipulator and we inject it via the manipulator. For the bladder, we put in a Foley and inject via the bladder using a bladder syringe into the Foley. And for rectum delineation, we use a rectal tube. And we can also use, I think actually the most useful option here would be using ICG in endometriotic surgery other than the ureter, because we know that we encountered deep endometrial in cases of deep infiltrating endometriosis. We are actually there are a lot of adhesions, fibrosis. It's actually very difficult to delineate an anatomy, and at the same time, you want to assess the location, the cause of the ureter. You want to avoid injuring vital structures, while also maximizing a resection of the endometrial deposits or the cysts. So actually, it's a very useful use in pelvic endometriosis. So to share a case where we use ICG to identify the endometriotic deposits, in which we did laparoscopic ovarian cystectomy and also resection of peritoneal endometriosis. Okay, so in this case, we gave ICG intravenously. This is the uterus, actually some green color on the womb as well, you can see. This is this is the left pelvic side wall, trying to look at the left ureter. Okay, and this is the left ovarian cyst. This is the right side. So this patient actually presented to us when she was 32 years old. She had 3 previous normal vaginal deliveries, and she was found to have a left ovarian cyst on routine body check. Clinically, she had some mild dysmenorrhea and low menstrual disturbance otherwise, and pre-op ultrasound showed a 7-centimeter cyst. So this is cyst here, and then we're trying out the different molds. You can see this is there are some fibrosis over here near the right uterosacral ligament. You can see also the uterine artery is also here. So we injected 6.5 mils of ICG intravenously by the anesthetist. The right tube and ovary were majority unremarkable, but you can see fibrosis and endometriotic deposits at the right pelvic side wall as well as near the right uterosacral ligament. So because we anticipate some blood loss, we gave 10 ml of diluted pitocin, about 20 units and 100 ml of NS, and injected into the base of the ovarian cyst before proceeding to the ovarian cystectomy. We proceed to dissection of the left ovary from its surrounding structures. And then we open up the ovary and then we perform the cystectomy. We're opening the cyst. So in this footage, the ovarian cystectomy has already been performed. You can see there's actually very minimal blood loss. Usually we anticipate quite a lot of bleeding from the raw areas, but after the picture scene, you can see there's not much fresh bleeding. Deposits over the right pelvic side wall and ligaments. So we're tracing the right ureter and its course. And then we will enter the Okabayashi space to identify the inferior hypogastric nerve and also the pelvic nerves. And then we will resect the right endometriotic deposit on the right pelvic peritoneum with monopolar scissors and pure cut with small see the paracelsus of the right ureter. And then after resection of the endometriotic deposits and the fibrosis over the side wall, we perform peritoneal lavage to clear, and we also check on our hemostasis. So it seems quite clean. So this is the post-op view. You can see the ureter here, the resection margin. This one is the left tube, left ovary after the operation as well. So other than this case, we also have another case of endometriotic cyst with bilateral hydronephrosis. And that patient was a 31 years old lady, para-O, who had already had history of ovarian cystectomy and pelvic endometriosis ablation back in 2016. She had a post-op adjuvant microgynon for 3 years until she was trying to conceive. And she then had a body check ultrasound because she would fail to conceive as well. And then she seen private, which showed multiloculated cysts extending from POD down to up to above uterus, 12 centimeters, and another left biloculated cyst. And pre-op ultrasound showed negative sliding sign at PLD and also pelvic side wall. There were also right kidney clubbing of calyces and left kidney with prominent renal pelvis. So preoperatively, CT urogram was performed. And there is mild left hydronephrosis and moderate right hydronephrosis. So in this case, we also did cystoscopy to catheterize bilateral ureters for the patient. So, but this was performed by the urologist because there's hydronephrosis. So we're not very sure if there are any other thing we might injure accidentally. We're worried that the anatomy may be affected. So that's why urologists kindly agreed to help us to catheterize bilateral ureters. And they kindly also did the retrograde the catheterization and using also a guide wire, and then use a bilateral retrograde hyelogram to confirm the position, and also took a bladder biopsy because incidentally not to have some cystitis over the trigone area. And this is actually our very first experience to use ICG injection inside the ureter. So this one is the diagnostic laparoscopy view. You can see bilateral ovarian cysts and a lot of fibrosis and vessels at the fibrotic areas. So we're introducing the other ports. And these are the intra-op images we took after ICG injection into the ureter. Okay, so we have got It's actually a lot of after quite a lot of dissection, we've got some raw area, so it'll be quite bloody on the screen here. So we are able to visualize bilateral ureters on diagnostic laparoscopy here.